Hello everybody, I'm Dr. Ahmed Hamdi, lecturer of cardiothoracic surgery. Today we will talk about pleural empyema. Under this subject, we will discuss the following items. 1. Definitions, which include A. Definition of empyema. B. What is the pleural space? C. What is pus? D. Other names of pleural empyema and a historical note about empyema. Second item is the etiology, which include spread into pleura, direct inoculation. Generally, there is parapneumonic empyema, represents about 60% of cases. Post-resection empyema includes about 20% of the cases. Third item is pathophysiology, under which we will discuss the different stages of empyema, including A. Exudation, B. Fibrino-purulent reaction, C. Organization. Fourth item is complications, which include early and late complications. 5. Diagnosis, which includes A. Clinical history, taking clinical examination, and different modes of investigations. 6. And last item is treatment, which include infection elimination or usage of proper antibiotic therapy. B. Pus drainage, which is the main line of treatment in empyema. C. Inflation of the collapsed lung. D. Space obliteration, and we will discuss it in details. E. Improve the general condition of the patient. And the last line is treatment or how to avoid the possible complications. So we will start. Throughout the following 4 slides, we will discuss the first item, definitions, starting with the term empyema. Regarding thoracic surgery, empyema is defined as collection of pus in the pleural space. However, generally speaking, empyema can be used to describe any collection of pus in a closed space, including, for example, empyema of gallbladder and empyema of pericardium. Thus, it's better to name it as empyema thoracis, pyothorax, or purulent pleuritis. In Latin, the syllable im means in, pyon means pus, pyemia means suppuration or the process of pus formation. Thus, empyema literally means in pus, referring to collection of pus around lung. In contrast, if pus collects within lung parenchyma or within lung substance, this disease is known as lung abscess. Therefore, pus in lung abscess can erode into a nearby airway and get coughed out, known as suppurative lung syndrome. While in empyema, pus, which collects in the pleural space, which is devoid of airways, pus cannot be coughed out. Instead, it needs to be drained by a needle or a surgery. Under certain circumstances, pus in the lung abscess can erode also into the surface of the lung, causing empyema on top of lung abscess. In this slide, you can see a diagrammatic illustration of the chest. On the right side, you can see ribs, intercostal muscles, and these green and yellow lines. The green line represents what we call parietal pleura, which lines the interior of the chest wall. The yellow line covered the external surface of the lung, referring to what we call as visceral pleura. Pleural space is the space between these two pleurae, or the parietal pleura externally and the visceral pleura internally. As you can see also on the left side, you can see this red line referring to parietal pleura, blue line referring to visceral pleura, and this white space in between, which refers to the pleural space. Thus, pleural space can be simply defined as the space between chest wall externally, lung internally, between the two layers of pleural covering of the lung, or between visceral and parietal pleurae. But what is the significance of this space? Why it is present even? This space is a potential space which, number one, contains a small amount of serous fluid not exceeding more than 0.1 to 0.2 milliliter per kilogram of body weight. This serous fluid lubricates the respiratory movements throughout the respiratory cycle. Number two, this space has a subatmospheric pressure, which means the pressure within this space is lower than that of air entering into lungs. Thus, the negative pressure within this space facilitates lung inflation during the inspiratory phase of respiratory cycle. If the fluid within the pleural space is changed regarding its chemical components or chemical structure, or changed regarding its amount, increasing its amount, it leads to what is known as pleural effusion. Thus, chemical components of this fluid changes under pathological conditions, leading to different forms of collections within this space. For example, it may contain exudate, it may contain serous effusion as in hyperalbuminemia and liver disease. It may contain pus as in empyema. It may contain lymphatic fluid as in chylothorax. It may contain even blood as in hemothorax. Thus, chemical analysis of the fluid collected in the pleural space is essential to differentiate between different diseases when the general aspect of the fluid collected cannot differentiate between the different diseases. Before we move to the next definition, you can notice on the left side the site of collection for pleural effusion, which is the pleural space. When any fluid collects in the pleural space, including pus, lymph, blood, or even air in pneumothorax, the pressure in the pleural space exceeds that of the air entering into lung through airways. Thus, this accumulated fluid will lead to lung collapse, and therefore, after you drain pus in treating empyema, you have to be sure that this lung is not entrapped or moving well during the respiratory cycle. Now, what is pus? The first thing you have to know is pus is a complete physiologic process. It results from the process of suppuration, which is a normal reaction of the human body towards a biogenic organism. Biogenic organisms all share the ability to initiate primary immune response, including mainly neutrophils. When these neutrophils invade the infected area, they usually die by the effect of lethal toxins released from the pathogenic organism, and when they die, they release lytic enzymes which cause necrosis and death to the surrounding other cells, including host tissue cells, the pathogenic organism, and other immune cells. Thus, eventually, pus will be formed of immune cells, including neutrophils, host tissue cells or necrotic tissue, and causative organism. Chemically, pus has certain criteria which help to differentiate it from other fluids collected in the pleural space under other pathological, other pathological conditions. These chemical criteria include pH of 6.2 to 7.2, acidic, however it may be alkaline as in case of previous infection. Specific gravity of more than 1015, glucose content less than 60 mg per deciliter, total leukocytic count in the pus of more than 15,000 cells per high power field, and presence of the causative organism, which can be detected by different staining methods. However, the most important criteria to define pus chemically is the Light's criteria, which depends on protein and lactate dehydrogenase presence in pus and comparing their presence into their concentration in serum. These Light criteria include protein in pus more than half of this in serum, lactate dehydrogenase more than upper two-thirds of the normal limit, lactate dehydrogenase more than 0.6 of serum LDH level. Empyema is one of the oldest surgical diseases. Hippocrates, 600 years before Christ, described empyemas and say in their texts, empyemas could occur in any part of the body and weren't distinguished from abscess, although the empyemas located in the thorax were described most often. Conservative treatment with medications composed of plant material and physiotherapy exercises was attempted first. If the patient didn't improve, open evacuation of empyema was undertaken. In the next 6 slides we will talk about etiology of empyema. There is no primary cause. Empyema is a case of secondary infection, or the pleural space simply receives infection from other site in the body or from the external environment. Contamination of the pleural space from a source contagious to it is the commonest cause of empyema, which includes empyema following pneumonia or lung infection, known as parapneumonic empyema, which is the commonest cause of empyema. 40% of patients with pneumonia will develop parapneumonic effusion, depending mainly on the type of the causative organism. The commonest organism to cause parapneumonic pleural effusion is pneumococci. 60% of cases will develop pleural effusion. 20% of cases with parapneumonic effusion will develop empyema, depending on many risk factors including age, nutrition state, immune state, and alcoholic state. The second commonest cause is direct inoculation of the pleural space with the organism, which may be due to accidental trauma as falling from height, motor car accident, or iatrogenic trauma following thoracic surgeries, including rib resection, lung resection, or any other thoracic procedures. Post-resection empyema or post-lung resection empyema includes about 20% of cases of empyema, most commonly following pneumonectomy, especially if associated with bronchopleural fistula. The rarest cause of empyema is the hematogenous spread or blood-borne infection from another distant infected site. Here you can see how contamination of a source contiguous to the pleural space occur. First site is lung, secondary to pneumonia. Second is the mediastinum, which is a space between two lungs containing heart in the middle space, and thymus lymph nodes anterior to heart, aorta, esophagus, and other many structures posterior to heart. Thus, for example, rupture of the esophagus will lead to leakage of saliva, food, and microbes into the pleural space and mediastinum. Third site is the chest wall infection, including rib osteomyelitis. Posteriorly is the spinal cord and the vertebral column, which may be also infected as osteomyelitis or as in Pott's disease, tuberculous abscess. Both subphrenic or paracolic sources are subdiaphragmatic sources, including amoebic liver abscess or paracolic collection of pus, which may pass through the pleural space through what is known as pleuroperitoneal connections or through a tear in the diaphragm as in post-traumatic diaphragmatic rupture or diaphragmatic hernia. Empyema may also follow direct inoculation into the pleural space, which may be due to a penetrating chest trauma or iatrogenic trauma following minor or major thoracic interventions. Thoracic intervention, including post-resectional empyema, is the commonest cause of empyema after parapneumonic causes. Post-resectional empyema is commoner with pneumonectomy, right-sided resections due to single bronchial blood supply, and following upper lobectomies. Here you can see this penetrating object into the chest cavity, injuring the lung, which may lead to collection of blood in the pleural space, which when become secondary infected due to inoculation of bacteria with this penetrating object will lead to empyema later on. In this slide you can see here the incidental or iatrogenic trauma following lung resection. Lung resections may be non-anatomical as in case of wedge resection, or anatomical starting from segmentectomy, lobectomy, bilobectomy, and pneumonectomy. The last and the rarest cause is hematogenous spread, which may follow osteomyelitis in a distant site from the chest as long bone osteomyelitis, forming a chronic septic focus, or late after pneumonectomy, late post-pneumonectomy empyema, which occurs within more than 2 months following resection. It is of insidious onset and of lower mortality compared to early post-pneumonectomy empyema, which occurs within 2 weeks after surgery. In this slide, we will talk about the third item, which is pathophysiology. Empyema passes throughout 3 phases to be completely settled or formed. The first phase is the exudative phase, where the attacking neutrophils release pro-inflammatory chemical substances, including interleukins and cytokines, which leads to derangement of the hydrostatic pressure at the arterial end of the capillary meshwork, with subsequent increased pulmonary interstitial fluid formation and increased capillary permeability, with accumulation of clear or slightly turbid fluid in the pleural space. This fluid, usually similar to serum in composition, with pH more than 7.2, glucose level more than 60 mg per deciliter, and LDH less than 1000 international units per liter. In this stage, this fluid is almost always sterile with no microorganism presence. Within the next 5 to 10 days, continuous inflammation and bacterial translocation leads to activation of coagulation cascade with excess fibrin deposition and fibrin remodeling, with low activity of the local fibrinolytic pathways, leading to formation of turbid, thicker fluid within the pleural fluid and fibrin threads between the visceral and parietal pleurae. In this stage, the fluid is usually has a pH of less than 7.2, glucose level less than 60 mg per deciliter, and LDH more than 1000 international units per liter, and usually is positive for the causative organism. Within the following 2 to 3 weeks, the fibrin deposited by action of fibroblasts undergoes more remodeling and reorganization, with formation of a thick peel between the visceral and parietal pleura, which causes lung entrapment, and the accumulated fluid is frank pus, which needs to be evacuated, and this pleural peel have to be excised to allow for lung inflation. Now we will move to the fifth item, or complications of empyema. Throughout the following 3 slides, we will talk about different complications of empyema, why it occurs, and how to avoid them. You can see here complications of empyema can be classified according to timing of occurrence into early and late complications. Early complications are those occurring within the first 6 weeks of the disease and include trapped lung or lung entrapment. Lung entrapment means inability of the lung to move freely throughout the respiratory cycle due to presence of adhesions or thick pleural peel between the visceral and parietal pleura, and thus the respiratory movements are halted and the patient cannot breathe well. Thus, as we have said previously, treatment of empyema is not directed only towards pus evacuation, it has also to entail adhesiolysis or removal of these adhesions to allow for proper lung inflation and deflation. The second early complication is the fistula formation. Actually, bronchopleural fistula with empyema is commonly occurring following post-resectional empyema, with many risk factors controlling this condition or promoting formation of this fistula. These risk factors include preoperative factors such as senility, debility, obesity, malignancy, chronic obstructive pulmonary disease, and operating on an infected field. Intraoperative risk factors including right-sided resections, upper lobectomies, right-sided pneumonectomy, and presence of lung or calcified bronchial stump. After the operation, prolonged mechanical ventilation or ventilator-acquired pneumonia or nosocomial pneumonia will facilitate occurrence of bronchopleural fistula. Bronchopleural fistula with empyema will allow the pus in the pleural space to be coughed out of the pleural space, resembling the condition of suppurative lung syndrome caused by lung abscess and bronchiectasis. Moreover, empyema can erode into the nearby structures, such as diaphragm, causing subpharynx collection, or into mediastinum, causing mediastinal collection. However, erosion into the nearby structures commonly accompany a chronic condition lasting for more than 6 weeks, which will lead to the late complications. Late complications include number 1, fibrothorax, functional resection, functional restriction of the lung movements, and what is known as frozen thorax. This term is used to describe a hemithorax or a part of the chest cavity which cannot move freely due to presence of extensive fibrine deposition or extensive fibrosis, leading even to fibrosis of the intercostal muscles. In such cases, surgical intervention should also include rib resection or multiple rib resection to allow the chest wall to move better and for better breathing. Chronic empyema is one of the late complications of empyema, which is defined as empyema lasting for more than 6 weeks. Risk factors for chronicity includes a bad general condition of the patient such as senility, debility, obesity, malignancy, infection, anemia, corticosteroid therapy, and anti-malignant chemotherapy. Another causes include incomplete evacuation of pus, insufficient antibiotic therapy, and presence of thick pleural pale or loculated pus within the pleural space. Another late complication include what is known as empyema nascens, which will be discussed better in the next slide. Empyema nascens formed when there is abnormal connection occurs between the pleural space and the subcutaneous tissue by eroding the intercostal muscle or the overlying rib by the process of chronic osteomyelitis. In such a case, pus collects both under the skin and in the pleural space. So when the patient coughs, pus underlying the skin will show pulsatile impulse on cough. Empyema nascens isn't common, however, its occurrence refers to chronicity, high virulence of the causative organism, or bad general condition of the patient. Usually, insertion of intercostal tube drains both pus in the pleural space and in the subcutaneous tissue. Empyema also can erode to the nearby left spine, causing osteomyelitis, can erode to the nearby pericardial sac, causing pericarditis, pericardial effusion, or even pericardia. It may rupture into the mediastinal space, causing mediastinal abscess, or it may invade the diaphragm into the peritoneal cavity. By reaching this point, we have finished the first part of Empirima lecture. Goodbye, and see you in the second part.